Hi, I'm Luke, and today I'm excited to share our work, Counterfactual Prediction Under Outcome Measurement Error. This is joint work with Amanda Coston and my advisors, Ken Holstein and Stephen Wu. In this work, we study a common setting in which organizations introduce a predictive model with the goal of improving a decision-making process. For example, consider a medical context in which a doctor aims to reduce the risk of cardiovascular disease by enrolling high-risk patients in an intensive care management program. Screening in a patient to the program can provide them with additional medical resources, which might avert poor health outcomes such as heart attack. However, the same patient might experience a poor outcome if turned away from the program. One challenge that arises in this setting is that we never observe outcomes under both possible enrollment decisions in model development datasets. Therefore, one of the decisions is an unobserved counterfactual. This challenge requires us to estimate counterfactual models of risk. An additional challenge is that we often don't directly observe the target outcomes of interest to physicians and model developers. For example, while a doctor might be interested in assessing the risk of a target outcome, such as biological heart attack, in practice, we observe a proxy consisting of heart attack diagnosis and medical records. Because heart attacks can be misdiagnosed, this can introduce outcome measurement error. Treatment effects of decisions and outcomes can interact with measurement error in nuanced and challenging ways. For example, we might miss more heart attacks from screened out cases due to less intensive supervision than for screened in cases, which might gain more physician attention as part of the screening program. In this work, we formally studied the interactions between treatment effects and outcome measurement error under a unified treatment-conditional outcome measurement error model. In particular, we offer the following main contributions. First, we develop a method for learning robust prediction models under treatment-conditional outcome measurement error. And second, and more broadly, we underscore the importance of carefully accounting for multiple intersectional threats to model reliability that can arise in real-world model deployment contexts. Let's begin by setting up our problem in a little bit more detail. Our goal in this work is to estimate the probability of a binary target potential outcome, such as heart attack. And under the potential outcomes framework, Y sub t is the outcome that would occur under the hypothetical case that we assigned treatment T to a given individual. However, rather than directly observing binary target potential outcomes, we have observational data that includes covariates, prior decisions, and binary proxy outcomes. We model the proxy outcome probability via a treatment-conditional outcome measurement error model. And this model assumes that the target outcome probability is transformed by a treatment-dependent false negative and false positive rate, but remains fixed across covariates. Throughout this work, we'll also require standard causal identification assumptions, such as no unmeasured confounding, positivity, and consistency. We'll now introduce our method for learning an unbiased estimator for target potential outcomes, given observational data. Under the standard risk minimization paradigm, we'd like to minimize the expected risk over target potential outcomes, where f sub t is a prediction function and L is a loss. However, the key issue here is that the target outcomes that we're interested in minimizing risk over are unobserved. Therefore, in our work, we construct a reweighted surrogate risk that combines a weighting function with a surrogate loss. And this risk is minimized over the treatment population T corresponding to the target outcome of interest. This risk can actually be minimized leveraging only the observed proxy outcomes available in observational data. Our theoretical result shows that the reweighted surrogate loss is equivalent to the risk with respect to target potential outcomes and expectation. We provide the specific loss weighting function and proof in our paper. An intuitive view of this result is that our approach applies a joint bias correction for treatment effects, outcome measurement error, and selection bias in parallel. However, importantly, this result requires knowledge of the measurement error parameters to construct tilde L, as well as the weighting function, which requires knowledge of propensity scores. And this motivates our practical finite sample algorithm, in which we first estimate weights and measurement error parameters. Then we use these estimates to minimize the reweighted surrogate risk over a finite sample. However, in many cases, you might be wondering, we don't actually know the measurement error parameters alpha and beta ahead of time in practice. Therefore, in our work, we also develop a method for estimating these parameters via observational data. A challenge in this setting is that the target outcome that we're interested in predicting is unobserved. And this requires us to make assumptions about the relationship between target and proxy outcomes. We address this issue by introducing a family of anchor assumptions, which can be flexibly combined depending on the problem setting. In introducing these assumptions, suppose that our target outcome is a biological occurrence of some disease of interest. The min-anchor assumption holds that there's a patient in the population that's at zero risk of this disease. And this assumption might be reasonable if we can rule out a given disease given detailed knowledge of patient physiology. The base rate anchor assumption assumes that we know the expected target outcome probability takes some scalar value C. And this quantity is often estimated as part of randomized controlled trials while estimating the conditional average treatment effect. Finally, the max anchor assumption assumes that there's an instance at near guaranteed risk of the disease. And this assumption can be reasonable if a diagnosis has been confirmed via additional gold standard tests or a biopsy. In our work, we show that these assumptions can be combined flexibly to identify measurement error parameters, even when one or more of these assumptions might be unreasonable in a specific setting. In our paper, we provide algorithms for parameter estimation over finite samples, given this identification result. Now, model evaluation is really challenging in this problem setting due to compounding uncertainty from outcome measurement error and from unobserved counterfactuals. Therefore, we start with a synthetic evaluation of our proposed methods, where we detail the setup in our paper. In this plot, we show the accuracy of several models as a function of total dataset size. The target potential outcome model, shown in black, has oracle access to the target potential outcomes, and thus it provides an upper bound on model performance in our problem setting. Our reweighted surrogate loss, shown in orange, performs reliably across sample size settings. However, we do see that performance deteriorates when measurement error parameters and weights are estimated rather than fully known, as shown via the dashed lines. We also compare against a surrogate loss model that does not apply reweighting, as in ablation, and we find the strongest reweighting benefits when the weights are known, as shown in bold. Critically, we find that models that do not correct for both outcome measurement error and treatment effects perform unreliably across all sample size regimes. We also conduct an additional evaluation with semi-synthetic data from the healthcare and employment domains. The Zhiwei data set is a randomized controlled trial examining the effect of Medicare enrollment on downstream health outcomes. And we predict diagnosis with a new active chronic condition 1 year after Medicare enrollment in a lottery, which serves as our treatment variable. The jobs data set examines the effect of job retraining on unemployment outcomes. And this data set contains both randomized and non-randomized cohorts. We predict unemployment under the various program enrollment options, conditional on covariates such as job history, demographic factors, and status in the training program. We introduce synthetic selection bias in both training data sets, as detailed in the paper, and we insert synthetic outcome measurement error by flipping diagnosis and unemployment outcomes with a known probability, alpha and beta. In this figure, we plot the bias and average treatment effect estimates across 5 error parameter settings. And as with our synthetic evaluation, these results show that models which do not correct for outcome measurement error and treatment effects in parallel perform unreliably across settings. In contrast, our proposed approach performs as well as an oracle model with ground truth access to the target outcomes, labeled CT in this plot, when measurement error parameters are known. However, we observe limited performance improvements due to reweighting in this evaluation, as shown by the comparison against the SL method. The right panel here shows performance of our reweighted surrogate loss approach with learned measurement error parameters. Critically, these results show that performance of our approach is sensitive to whether the anchor assumptions that are used in measurement error parameter estimation hold. Specifically, because the max anchor assumption is violated for both OHI and jobs data, our approach performs poorly when this assumption is used for measurement error parameter estimation. However, our approach performs more reliably when we replace the max anchor with a base rate anchor, which is a reliable, or which is an assumption that's satisfied in our particular setting. Thank you for your time and attention today, and we look forward to roundtable discussion.